Welcome, ladies and gentlemen. I'm Dr. Silva. Thanks for joining me. Today I'm going to talk to you about Viloxazine, Qelbree. This is a brand name only medication that is approved by the FDA for attention deficit disorder for ages 6 and older. But it's also commonly prescribed off-label for major depressive disorder in the United States. A non-stimulant medication for the treatment of ADD, ADHD. It has a unique mechanism of action. It's a norepinephrine reuptake inhibitor, so it blocks the reuptake of norepinephrine, as well as being a partial agonist, a stimulator of serotonin 2C subtype receptors. So it stimulates those receptors, but only partially, i.e. not as much as serotonin would, as well as being an antagonist, a blocker of serotonin 7 and 2B receptors chiefly. The fact that it's a norepinephrine reuptake inhibitor, it blocks the reuptake of that neurotransmitter at the synapse, the gap between neurons where communication takes place, boosts norepinephrine, which is called noradrenaline in the UK. It's a major hormone released by the adrenal glands. By blocking those norepinephrine reuptake pumps, the norepinephrine transporters, we increase noradrenergic neurotransmission, which increases the concentration of norepinephrine, which is conducive to attention deficit disorder. This action may also increase dopamine in the prefrontal cortex. In the frontal cortex, which largely lacks dopamine transporters, dopamine is inactivated by norepinephrine reuptake as well. Blocking that also increases dopamine, thereby increasing dopaminergic neurotransmission, but only in the prefrontal cortex. Partial agonist actions at serotonin 2C receptors may also enhance dopamine release, and antagonist actions at serotonin 2B and serotonin 7 receptors, so again, blocking those, are thought to enhance serotonin release. Qelbree is available in extended release capsules of 100, 150, and 200 milligrams with a maximum dosage for adults of 600 milligrams once a day, up to 400 milligrams daily for children and adolescents. The capsules can either be taken whole or they can be opened and the contents sprinkled over applesauce or pudding. The entire serving needs to be consumed within 2 hours without chewing, without grinding the individual beads. Otherwise, the extended release property of the preparation is disruptive. And I can't imagine that would taste any good. Otherwise, the capsule can be swallowed with or without food. The dose of a single capsule is not meant to be divided. We need to monitor blood pressure, both sitting and standing, as well as the pulse at baseline and after starting the medication. And then again, anytime there's a dose increase, and just periodically during treatment. Monitoring weight and height is always important in children, even though Qelbree is not a stimulant, and long-term studies of pediatric patients up to 3 years for patients ages 6 to 17 years demonstrated no effect on growth, height, or weight. Qelbree is an important non-stimulant alternative for the treatment of ADD, ADHD, especially in kids, along with Strattera, atomoxetine, Intuniv, guanfacine, and Capvey, clonidine. I have a separate video in which I talk about why the non-stimulants are less effective in adults. My controversial Why Strattera Doesn't Work in Adults video. I got a lot of consternated comments on that one. Please check it out. Long-term open-label studies show continued efficacy of Qelbree for up to 3 years in pediatric patients and up to 2 years in adults, as well as sustained safety. There were no newly emergent adverse effects with sustained use of this medication. No long-term side effects that were not initially apparent. It's not habit-forming, and like more traditional stimulant medications for ADD, it's a medication that can probably be discontinued abruptly. It can probably just be held whenever we decide to suspend or discontinue therapy. For example, in the summertime when the kids are off school or on the weekends, if they don't have a lot of homework, if there's not a lot of hyperactivity or impulsivity, or in adults, whenever it's not really needed. I always recommend only PRN use of ADD medications in adults. PRN meaning as needed, and adults are good about just being able to take them when they need them. So what are some of the notable side effects of this medication? Fatigue and sleepiness occur in a significant minority. This is independent of insomnia, which is also possible as a side effect. We can also see irritability and headaches, as well as decreased appetite, but we see less appetite suppression compared to stimulants. So while weight loss is certainly possible, this is typically much less. There can also be nausea and vomiting in the extreme, dry mouth, constipation and increased heart rate and blood pressure are possible. So monitoring is very important. Norepinephrine inhibits acetylcholine release, which increases heart rate by inhibiting the actions of the vagus nerve, the 10th cranial nerve. That also increases blood pressure, but the primary effect on blood pressure and pulse comes from norepinephrine's direct effect on noradrenergic receptors in the cardiovascular system, including on the peripheral arteries, causing vasoconstriction. This increases peripheral vascular resistance and thereby increases mean arterial pressure. Other unwanted actions of norepinephrine on acetylcholine release cause the decreased appetite, the dry mouth, the urinary retention, and constipation, the latter two of which can be truly problematic for older individuals. As far as activating suicidal ideation and behavior, always a concern with children taking psychotropic agents, this is rare but should always be evaluated in all patients, including young adults. The FDA's black box warning applies only to individuals ages 23 and younger, but that's an arbitrary cutoff, really. Mental health practitioners prescribing psychotropic medications should always evaluate and reevaluate patients for suicidal thoughts and behaviors. Because viloxazine doesn't enhance dopamine activity in limbic areas, there's no euphoria and thereby no abuse potential, just like Strattera. Dopamine is only increased in the prefrontal cortex, where we need it to be for symptoms of poor attention and concentration, because of the lack of dopamine transporters in that area of the brain. Dopamine relies on the norepinephrine transporters. So if we're blocking those, as both Strattera and Qelbree do, then we not only increase the concentrations of norepinephrine, but also dopamine. In the limbic system, dopamine transporters are present to mop up the dopamine that's released, taking it back up into the neurons that release it. Neurotransmitter reuptake, thereby limiting the action of dopamine. That's why reuptake inhibitors increase the action of whatever neurotransmitter they're inhibiting the reuptake of. And since Qelbree has no action on dopamine transporters, that homeostatic mechanism in the limbic system is unperturbed and dopamine levels stay the same in those areas, the areas that might trigger addiction. I hope that's clear. In the nucleus accumbens, well known for the brain's reward, motivation, and pleasure circuits, norepinephrine transporters are largely lacking. Lazodone doesn't increase dopamine in that part of the brain because there are plenty of dopamine reuptake pumps. There are significant drug-drug interactions as well. Qelbree strongly inhibits the cytochrome P450 liver enzyme 1A2, which means that other substrates metabolized by that liver enzyme undergo less metabolism, and their corresponding blood levels increase. The liver will still be detoxifying the body by removing those compounds, but it will be doing so more slowly because the enzyme that catalyzes those reactions is being suppressed by Qelbree. And so co-administering viloxazine with a CYP1A2 substrate with a narrow therapeutic index is contraindicated. What do we mean by that? CYP1A2 substrates, like caffeine, that can get toxic with relatively minor increases in blood concentration, i.e. they have a narrow therapeutic range as opposed to a broad range of blood levels that are okay, are relatively contraindicated. It's not an absolute contraindication. Patients taking viloxazine who also consume caffeine might be advised to either reduce their caffeine intake, stop caffeine consumption earlier in the day if they're dosing in the morning, so no more morning coffee, or switch to taking viloxazine at night so that Qelbree peaks during the night and there are less drug-drug interaction effects during the day when you're more likely to be drinking coffee. It can also reduce the clearance of CYP2D6 substrates. 2D6 is a famous, very common cytochrome P450 system enzyme that's involved in the metabolism of a lot of psychotropic medications, including Strattera, if it's being co-administered. And there are other significant drug-drug interactions. Patients who are taking MAO inhibitors shouldn't take Qelbree, including for up to 14 days after MAOIs are stopped. Please see my video on the monoamine oxidase inhibitors for more on that. The onset of Qelbree's therapeutic actions can be seen as early as the first week of dosing in ADHD, and its therapeutic actions may continue to improve for up to 8 to 12 weeks. Like so many drugs, an early positive response, which in this case is defined as within 2 weeks of starting treatment, may predict efficacy outcomes at 6 weeks. In either case, you'd want to wait until at least 6 weeks, as long as the medication is being well tolerated before passing judgment on any given dose. So if we see a positive response in the first few days, within the first week or two, that's a very good sign. If we don't see much of a response, it's not necessarily a negative sign. We just need to stick with it up to 6 weeks. If it works, effects are consistent over a 24-hour period, which is why we can move dosing to bedtime if necessary. The same is true of Strattera. Strattera can sometimes make people sleepy, especially children. And because it works all day, even if you take it at night, it works all the next day. In children that actually have ADD, then we can dose it at night if it makes them sleepy. So the same is true of Qelbree, ostensibly in both children and adults. If the patient feels fatigued or sedated, or we want to avoid caffeine but still have our morning cup. Treatment should be continued indefinitely so long as improvement persists, possibly on into adulthood. There is some positive long-term data, as I previously mentioned, and there's nothing to suggest that long-term treatment is contraindicated, that it's not safe. There are also open-label data that provide preliminary support for the safety and efficacy of combining viloxazine with stimulant treatment in pediatric patients, those with only a partial response to stimulant monotherapy, i.e. adding Qelbree to a stimulant like methylphenidate or amphetamine salts in children that are getting some response but not the full response that we want. Open label meaning that both the researchers and the participants knew that Qelbree was being added and not a placebo. It's not a double-blind situation. So it can be combined with stimulants, and that's something to consider for those of you treating children out there if it doesn't respond right away, or for those parents of you out there that may be watching this video. The potential advantages of this medication are obvious. There is no known abuse potential. It's not a controlled substance. It's not a scheduled drug. Refills are possible, meaning you don't have to have a new prescription each time you visit the pharmacy, so it's more convenient both for the practitioner and the family. There are no known withdrawal reactions. The medication can be suspended overnight when necessary, in most cases. And so far, it's the only non-stimulant with the option to open the capsule and sprinkle contents on applesauce for patients who are unable or unwilling to swallow pills. Not uncommon with very young children. All of the other medications that you can do that with to date are stimulant medications. Viloxazine also targets depressive and anxious symptoms via its multimodal mechanism of action, involving serotonin 2C, 7, and 2B receptors, in addition to norepinephrine reuptake inhibition, which we know all by itself has antidepressant actions. Viloxazine enhances serotonin as well, though in the frontal cortex, the amygdala, and the nucleus accumbens. This medication has proven efficacy as an antidepressant. It's been approved for depression in Europe for more than 20 years. Like Strattera, viloxazine's noradrenergic actions, increasing norepinephrine, particularly at the level of the spinal cord, may be useful for the treatment of chronic pain. And also, pain and mood go hand in hand, so if you're treating somebody who has major depression and chronic pain, this may be a good choice. Norepinephrine reuptake inhibitors in general may be a good choice, like Wellbutrin and Strattera. Its serotonin 2C partial agonist actions may enhance viloxazine's efficacy, specifically in treating impulsivity. The potential disadvantages of this medication: in a lot of patients, viloxazine may not act as rapidly as stimulants do when initiating treatment, not surprisingly, and viloxazine may not act as robustly as stimulants as well. Again, this is really no surprise. So that's it. That's Qelbree in a nutshell. Thanks for tuning in, and as always, questions and comments are welcome.